Hello, community. I'm Naomi Anderson from Aged Care Ready and founder of our wonderfully supportive Aging Parent Support Group on Facebook. Welcome to our 5th session. I actually had to go back and check what number we were up to because I lost count. But I'm very thankful and happy to see you all here with me today. And I'm so thrilled to introduce you to our guest today, who is Dr. Jessie Zanker of Aria Health in Victoria. Hi, Jessie.
Hi, Naomi. Thank you for the invitation and for welcoming me to the group.
So tell me, before we start, tell me a little bit about yourself and a little bit about Aria Health.
Sure. So first of all, I'd like to say thank you everyone for tuning in. I think it's wonderful that there's a group like this that exists and there are people out there like you very caring for your parents, which is part of the inspiration as to why I became a geriatrician. And if my mother's listening, sorry, Mum, I'm talking about grandparents there. I don't want to offend you by saying you're in the aging category just yet. So about myself, so I'm from regional Victoria, from Echuca, and I grew up there and had a close-knit family and had grandparents who experienced different forms of illness. I was particularly close with my grandmother, who experienced Parkinson's disease. And at that time, I was really interested in her health and hoping to improve her quality of life in any way that I could. And so sought to study medicine and did so. And it was only after practicing in medicine for some time that I realised that geriatrics, or the study working with older people, was the area that I was most interested in. And I think that's for a few reasons. I suppose naturally being a bit nerdy, I'm interested in the science aspect of things, but I'm more interested in the human side of things and the way in which ethics and individual liberties come into the care you provide for people and how you communicate that with people. And that really drove my interest in geriatrics, because that's where the combination of all of those things meets. So I sought to study that and then have been practicing as a geriatrician, which we do have a bit of an image problem in terms of the name geriatrician is a bit complex, and a lot of people haven't heard of it before and thinks it sounds a bit like a magician or something quite obscure. But we really focus on looking at the whole person and the person in their context, in the context of their family, their background, their education, their language, and most importantly, what their values and preferences are and goals that they wish to achieve in their life. And thinking about the illnesses they experience as part of that, but not the focus, and focusing on how you can optimize people. And so that is where I focus my energies as a geriatrician. And I set up a group called Aria Health with a couple of other geriatricians who share a similar interest. And together we provide geriatrician services to Melbourne and regional Victoria. But in addition to that, I have appointments at University of Melbourne. I'm undertaking a PhD and I'm a lecturer and tutor at the medical school there, and hold an appointment at Echuca Regional Health when I visit home one week a month. Yeah.
So you really know your stuff.
Well, I don't know if I know myself. We're always learning, and that's the thing I think that's really important about the people that I work with in our elders, is that you've got so much to learn from them. And so I'm always, I suppose, learning about different people and their experiences, because everyone experiences illness differently and has different aspirations as well. And I suppose it's important that we don't take a one-size-fits-all approach, that everyone is individual and we need to match that.
Absolutely. And today you did mention that you look at the person holistically, but today what I really would like to talk about is cognitive impairment and dementia specifically, especially now given the COVID-19 situation. I think this type of information and having these conversations is more important than ever. So let's start by some of the questions that you and I had already discussed, and then we'll go through some community questions. So for the people listening out there, what is the difference between memory changes with aging versus dementia? Is there a difference, or is it the same thing?
It's a really good question, one that's raised often, and it's often one that both people and families put down memory changes of concern to normal aging. So there is, with normal aging, a range of things happen in the body and in the mind. And we do know that, for example, if you're doing this test, it's a common test we do to assess someone's memory and cognition and thinking. We do expect to see a couple of points out of 30 drop off every few years once you get over the age of 75. And that's actually normal. So the normal for you and I, Naomi, doing that test would be a 30 out of 30, but the normal for someone over 90 might be 24 or 25 out of 30. Okay? So it is normal to get a bit of a decline with memory, particularly recall with age, and also other areas of thinking. And it's not just memory that comes into this. Mm-hmm. The difference with cognitive impairment and normal changes with aging are where that change is being noticed by the individual or others, and it's of concern, and progressing to a stage where those impairments that have been noticed are impacting on someone's day-to-day function. Mm-hmm. So yeah, it's normal. It's common for people to have to compensate in certain ways. That's not necessarily dementia, but if someone needs family members to take over certain duties that would ordinarily they be able to do or could do before, and the only reason they can't do them is because of the memory, then that's a concern, and that's a good trigger for getting an assessment, even though there are other triggers earlier on in that can be considered as well.
So when you say these day-to-day activities, is that things like finances, like if they're struggling to manage their finances or money's going missing and they just can't remember where they're spending it? Is that sort of what you mean?
Yeah, so there's a way of categorizing these things. So you might find that for the listeners out there, if they've been involved in healthcare, they might get asked, or their family member might get asked a range of questions that might seem intrusive at times about, well, do you shower yourself? Do you pay your own bills? Who does the cooking? Why does John do the cooking and not Melba? Those sorts of questions. Yeah. Do you pay the bills? If not, why? Who is that? Because you're forgetting them or are overdue? Other sort of activities, and we call these activities of daily living. So you might hear this term being bandied around, and in the health sector, people often abbreviate it as ADLs. So we really put them into the shape of personal ADLs. That's like your dressing, grooming, showering, your self-continence care, those sorts of things. And then you've got your community activities of daily living, or community ADLs, and that could be driving and transport, communication with others, being able to go shopping. Then you've got your domestic activities of daily living. That could be gardening, washing the windows, cleaning, other domestic duties, and often the bills and that sort of thing fall into those.
Sure.
So you can actually, most geriatricians and particularly people that are particularly interested in this in the allied health field are occupational therapists and physiotherapists, because when they're targeting their rehab, they look into how can we improve these things that this person can do at home. But if there are deficiencies and they're unable to do them, why is that? And do we need to be concerned about that?
Yeah. Okay. So what about those circumstances where English may be a second language, or somebody never learned how to read or write or didn't go to school? How do we differentiate between that and, say, cognitive impairment?
That's a really good question. I think that comes into the idea of how do you actually assess someone of what's normal and what's not. So I think that question leads into that comment, I suppose, where the important thing about an assessment, and I think this is fundamental about most assessments in medicine, is the history. And so finding out from that individual and the next of kin, family members or interested persons, the GP, what that person's been like. So we'll always start by finding out where someone is from, where they're born, how long they went to school for, what sort of education they had, what sort of work they did throughout their life. We'll always ask questions about children or grandchildren, try to get people to remember those names, and that gives you little insight into what's going on with the memory, because those sorts of things you don't necessarily need to have had a high education to retain. Most people normally can retain those things. So certainly when we're assessing someone who hasn't learned how to read or write, we have to take a different approach, and it's mostly based on the history and being adaptive to the way you actually do assessments. So those normal assessments, like the testing that we do, might not apply appropriately, and so ensuring that we do something that's humane and respectful, because often people are quite sensitive about illiteracy or numeracy, which is the terms to describe not being able to read or write. And then with English as a second language, there's certain ways you can assess people using interpreters or translators, and an assessment really needs to be undertaken by a qualified interpreter or translator and not relying on family, because while family are fantastic and very supportive, it puts family in a difficult position if they're feeling that they have to translate things, and it can strain relationships. So we always try to use someone independently who will translate that information as we say it, and they know the medical lingo and those sorts of things as well. So we do take all those things into account, and there are different tests you can apply as a doctor when you're assessing someone based on those factors.
Okay. And for your standard testing, I guess you would call it, how is dementia diagnosed? What does the assessment actually involve? And I guess coming from a family standpoint, do we as a family member get any questions asked of us when our loved ones get assessed?
Yeah, so certainly that's how it should be undertaken, and that's the standard. So the standard in public health systems is through the Cognitive Dementia and Memory Service, and a key part of that is what we call the informant history. Now, knowing that sharing information as a family member about your loved one who you're concerned about may create tension if that's undertaken in their presence. And so as respectfully as possible, those histories need to be undertaken. And most of the diagnosis of these seemingly complex things is through the history. Has the family members noticed changes? Has the individual noticed changes about themselves? And what are those changes? And in an assessment, I suppose it's probably worth speaking about what an assessment with a geriatrician like myself would feel and look like. Sometimes I speak with family members in advance of that appointment to gain some information. Often questionnaires are sent to family members. There are 2 questionnaires that are really useful to compare what your loved one's memory was like and thinking 10 years ago until now. That's called the IQ code. That's a really good one to use. And that just provides a bit of information in advance, particularly if there's concern about sharing information in front of one another, as respectfully as possible, and seeking consent to speak with family members is really important in terms of doing that. So yes, family members' concerns are heard, and usually the conversation will start off very much developing a relationship. For people who might be concerned about their memory, or who don't want to be seeing the doctor because they think we're going to diagnose something wrong with their memory, often there can be that reservation there in guarding. And so being able to be as warm and as compassionate, knowing that the concerns that they might be feeling ahead of the appointment and during the appointment is really important. So it usually will start off with those questions that I sort of ask, where did you grow up? What are your kids like? Those sorts of things. And developing that relationship, and you can gain some information that way as well. To go to the second part of your question is, so what testing is done? Is that what?
Yeah. So how is dementia diagnosed, I guess? Yeah.
So dementia itself is a large term that embraces a number of different causes. Okay, so the way to think about dementia is there needs to be concern. So that's called subjective. It's coming from someone. So it could be the individual who has concerns about themselves or a family member. There needs to be a decline and a lower performance on cognitive testing. So we have a range of tests, some of them I mentioned before, that we do in a consultation, and that needs to be significantly lower than the normal for the age group, and education status. And those things combined have resulted in what we call functional impairment. So that's an inability or a difficulty performing some of those tasks we spoke about before. And so you can have memory impairment, family members can be concerned about it, but if there's no functional impairment, then clinically dementia it's difficult to diagnose at that time. Okay, there's no functional impairment, but it does mean that we'll be more alert, and that can fit into the category of something else called mild cognitive impairment. So mild cognitive impairment is not dementia, but it is another syndrome. And we say syndrome because it means it's not a disease in itself. It's a syndrome where someone has some concerns about their memory, or you do, and they're not performing as well on tests, but it hasn't impacted their function. Okay.
Right. And could that be fleeting? Could that come and go? Or is that pretty permanent, the mild cognitive impairment?
So mild cognitive impairment in general, so what we say when it's diagnosed, so we do the tests, they're the written tests, then we do some brain tests as well, some scans to look for any sort of signs of what might be driving it. But the imaging brain tests aren't the 100% answer. And we do blood tests to make sure there's no other causes that we can reverse that could be causing the memory to go down. So mild cognitive impairment, the general way to look at this is that about over the course of 12 months, about 1/3 people will progress onto dementia, but about 1/3 of people will stay the same, and another third might improve slightly if you intervene in the right ways, keeping the mind active, improving mood, healthy diet and exercise, managing blood pressure, all these other things. So there can be some improvement in mild cognitive impairment. And when that's diagnosed, it's a trigger to say, okay, we need to be checking in regularly with the doctor, doing the same memory test to see if there's declines and if there's anything we can do at that stage.
Sure. So moving on to the actual side of dementia, how many types are there and which ones are the most common?
So there are lots of different types of dementia. So a way to think of dementia is there's an umbrella term that encompasses a range of different causes. The four main causes to be aware of, or that occur most commonly at about 90%, so 9 out of 10 people with dementia will have one of these conditions. So for many of you, the most familiar you would have heard of is Alzheimer's disease. So Alzheimer's disease is actually the disease that causes the dementia. It's a disease. Okay. So that accounts for a vast majority of the cause of dementia. Then there's a second type called vascular dementia. So vascular related to the vessels. And there can be a mix between vascular and Alzheimer's. So often we see people have features of both. And I can talk about the key features of each as well. Then there's another type called Lewy body disease. Now, Lewy body disease is slightly different, where it describes these things that occur in the brain called Lewy bodies. That actually occurs in Parkinson's disease, but it also occurs in Lewy body disease causing dementia. So that in itself is also another term. And then finally, frontotemporal dementia. So that's a type that occurs typically in younger people. And affects behaviour and personality mostly. That often comes before the memory changes. So without giving you too much information and overloading you too much, there's a simple way to think about the two most common, which are Alzheimer's and vascular. So I usually use an analogy called the filing cabinet. So often people will say, oh, my memory's fine, I remember everything from the past. I remember where I went to school, my kids, and all that sort of stuff. But the memory from last week, I couldn't tell you what I ate for lunch yesterday. Those sorts of things. So in very general terms, so Alzheimer's occurs in a certain part of the area of the brain, but vascular can occur anywhere, and it's often related to damage over time, like wear and tear. We go out in the sun. Over our lifetime, our skin will change and appear and change its appearance. If our brain is exposed to sort of stress over time, when I say stress, I mean high blood pressure, cholesterol, and even stress itself, it also gets a bit of damage over time. And so depending on where that damage is, you get different symptoms. In general, I like to think about a filing cabinet. throughout our life, we're putting information into that filing cabinet and we're storing it away, and we can usually most of the time retrieve it out when we're called upon. When Alzheimer's disease starts, often people don't file the information anymore. So it's not, they've got the information still in there from the past, but it's how to extract that information that or how to put that information in. So it's not like it's even gone and been filed. So it's hard to extract. But vascular dementia, I'm speaking in very general terms, is like the person can put it in there, the new information. So they can put in information about what they had for lunch yesterday, but they don't know where they put it. And so often you need to provide a bit of help and say, no, you said you wanted eggs in the morning. Did you have eggs for lunch? Oh, no, I didn't have eggs because I had them the day before. So they often need a bit of prompting to get that information out. And there are different features as well, but that's largely, in general terms, the differences.
That's a really good analogy. I guess from my standpoint, being a registered nurse, I have always come across these different types of dementia, and no one's really quite explained it that simply. I understand that's, you know, the whole emphasis on of your analogy, but it's a fantastic one, especially for those that haven't been in the medical field and have got these loved ones that do have either Alzheimer's or mixed or vascular dementia. Are there any types of dementia, you touched on a couple others prior to this, that really affect personality traits or hallucinations, or is that more mental health?
That's a really good question too. So in general terms, all of the dementias can cause certain changes in personality or can cause different, what you say, hallucinations. But I'll stress that those are uncommon, okay? So most people with dementia don't experience hallucinations and those sorts of things. And most people, about half people we think with dementia aren't living in nursing homes either, okay? So they are living at home. So it doesn't mean a diagnosis of dementia doesn't automatically mean living in residential care as well.
Absolutely.
The one that's and that's an important thing for family to know, that there are supports out there, and your service, Naomi, is one of those things that can help link those supports. But there are supports there to make plans over time to find when the time's right for you and your loved one. With frontotemporal dementia, that's pretty classically characterised by behavioural and personality changes, but that really makes up probably less than 10% of the dementias. Okay. And that tends to happen in younger people, 60 to 70, and depression can be a key feature of that too.
Yeah, that was one of my questions on my list. Can depression lead to dementia? Has it got any impact on dementia?
So depression does affect our memory. If anyone out there, knowing that 1 in 4 people can experience a mental illness throughout their life, and many will experience periods of depression or grief, that we know in ourselves that our memory doesn't work as well in those situations. Things don't stick, or you're unable to concentrate on the information you're receiving. And so we know that particularly for a lot of the people that I see and geriatricians see in the age group they're in, they might have experienced significant life changes, significant loss of loved ones or their partners, and they also might experience a degree of demoralisation at the change in their physical status and their health. And so a key thing for every person being assessed for cognitive changes or dementia is to investigate for depression. So I routinely do that for everybody, and exploring how that person's feeling. Is the cognitive changes, or are the cognitive changes we've observed due to declining mood and the impacts upon concentration? And you can get insights into the difference, whether depression might be playing a role based on how people perform on their cognitive testing, because it might not fit into the patterns you see in Alzheimer's or vascular or all the other types of dementias.
Mm.
So when there is depression causing significant memory problems, causing impact upon function, the old term for that was pseudo-dementia. Pseudo being sort of something fake or not real, so it's sort of type of thing that's mimicking as dementia but not quite dementia. And so treating that can reverse the cognitive impairment in those situations. With regards to depression throughout life causing dementia, now there are certain associations. And I say associations is that there are lots of things we can do throughout our lives and experiences that we have that can contribute to dementia in later life. It doesn't mean they cause it. Okay, so having depression in young life doesn't mean that you'll definitely get dementia. There might be a very slight increased risk, but the jury's still out on that, and that's not cause for worry at all. By far and away, there are more significant contributors, and certainly that's not something that I think people should be worrying about. Rather focus on how they feel at that time and working on their mental health for the present time.
Sure. And just to go with that train of thought a little bit and slightly off on a tangent, does sensory deficits such as hearing loss or vision loss impact dementia? Can it cause it or anything like that?
I'm really glad you asked that question because we have recently found the significant bodies of evidence showing how significant hearing impairment does impact upon memory. So first of all, untreated hearing impairment really increases your risk by about the odds of getting dementia by 2, so times by 2. And if you think about it, while we're sitting here, well, at the moment I can hear that my partner's got the TV on out there and there's some pots that are clanging. Hopefully you can't hear all of that.
No, we can't.
But I'm subconsciously thinking about that and thinking, well, I have to tell them to be quiet. And so my brain's actively working. You know, you might hear a car go past, you might hear some birds outside of the trees rustling. You're taking all that information in without realising it, and your brain's thinking, okay, do I have to be worried about that? No, not really. And weighing up the risks and benefits of it. If you can't hear a lot of that stuff, there's a lot of time during the day where your brain's sort of having a bit of a rest and falling asleep. And so if you're not using it, there's more, this is the theory that there's more chance of losing it.
So it's like a muscle.
Yeah, exactly. And then with dementia itself, if there is cognitive impairment already, cognitive impairment without dementia, I always get people to get a hearing test or request that people get a hearing test and get hearing aids before we confirm a diagnosis, because you can see dramatic improvements in people's memory if they've got significant undiagnosed or untreated hearing impairment. And then if there is a diagnosis of dementia, really important to have people wear their hearing aids to reduce the rate of decline as well.
Sure. I've got a couple more questions for you, and then I want to go to community questions that have been asked. Firstly, what help is available in terms of medications, treatments, or trials? Is there anything available for those families who have got a loved one who has got a diagnosis?
Absolutely. So you may be aware there's a huge amount of interest in this space because of the numbers of people who are affected and the importance of improving the quality of life of older people. So there's a great, so firstly in terms of what treatments there are, so you should never feel like there's nothing that can be done. And the greatest form of treatment at the moment is knowledge and empowerment of people and having support around you. There are lots of what we say non-medication treatments, like keeping active and healthy. One of the best treatments is exercise. It reduces the sugar load on the brain. It can significantly reduce the risk of developing dementia, and it's really good for people with dementia in a controlled way. And it has a lot of other benefits on physical health and sociability as well. With regards to the medications, there are approved medications for dementia, but not at this stage for mild cognitive impairment. There's a nutritional supplement available that's shown to improve people's score by a couple of points, 1 to 2 points on the test out of 30 that we commonly do. and information on that is available on the Dementia Australia website.
Mm.
And there's a few medications that are available as well, and they similarly improve in some people the score by 1 to 2 points out of 30. There are side effects with all of these things though, and a lot of people experience uncomfortable side effects, particularly related to the gut, and increased gut motility and discomfort that way. And so they're not tolerated by some. It's important to note that the medications are not a cure. So a way that I like to talk about them, and not every clinician will agree with this approach, but we don't think they change the way the disease evolves. So the time frame of the disease and it doesn't really change based on the use of these medications. It's like having arthritis in your knee and your knee's sore. You take a Panadol, the knee feels temporarily better, but the reason behind the knee being sore is still there and unchanged.
It's a Band-Aid fix.
Yeah, it's a Band-Aid fix, but it can be a Band-Aid fix that can be really beneficial for some people. So some people do get a good response, and we don't really know who's going to get a great response and who isn't. But the medication in certain types of dementia, like Alzheimer's, has shown across a population of people who are treated and trialled with it that it can increase your time living at home independently.
Yeah.
Okay. But as I said, the caveat is it's not tolerated by a lot of these medications aren't tolerated by a lot of people, and they can they might not improve things at all. And don't be disheartened if they don't, because there are always other options. The second part of that is, are there trials? There's certainly some amazing trials going on at the moment. So there's something called the ADNET, ADNET, clinical trials unit that's right across Australia, and they're looking at ways to improve and looking towards a cure for dementia. And I'm not sure where most of your listeners are based, but you can look that up online and find out if there's a centre. Now, because of COVID at the moment, those sort of clinical trials have ceased for the next few months until it's safe to bring clinical trial and vulnerable older adults into clinic settings regularly. But there are always options, and if you're interested in those, it's worth asking your doctor about what those might be. They might not know offhand, because hopefully we can promote these things, but not always, and it's always worth just checking in about those.
Sure. Thank you so much for answering those. Now, are you happy if we throw to some community questions?
Absolutely.
So for those who are watching and listening to us live, I do have my comment section open. So if you do have some burning questions as we're going, please do ask them. It's always best to ask while we do have Dr. Zanker with us tonight. The first question I have is, can you drive with dementia if you've been diagnosed?
So really good question, and probably the most common reason why people are most fearful of coming to see their doctor with cognitive concerns. So the way to describe how we approach this is that the diagnosis of dementia requires reporting, or the individual who's been diagnosed to report this to VicRoads, and they make a determination based on the report from the doctor as to whether the person can drive or not. Once the geriatrician or the doctor makes a diagnosis of dementia, we're obliged to inform the person that we need to report this. And this is not saying that they're a bad driver, and this is not saying that they won't retain their license, but that's often made, that decision is made by the VicRoads medical officer. And often, because of the concerns, not just about memory, but about reaction time and the way people see images in space. So often the depth perception changes with dementia. You can't see the distance a car, or perceive properly the distance a car might be coming from or travelling, the speed it's travelling at. And so we do have to make that report. And unfortunately, we have to inform the person that if they do drive and there's an accident, when that report's been made, that they might not be covered by insurance, and there can be issues related to culpability. So while it's a really hard thing, it's important to be honest with people about the risks. And often a trigger point for me getting the history from people is, well, do you drive the grandkids around? And often if they don't, and they're used to do school runs, that means that their children aren't really comfortable with them driving the car and their kids being it. And that's often a trigger point for people and families to say, okay, perhaps we should get this looked into. So driving assessments can be undertaken at the request of Vic Roads. And if there is concern regarding driving of an older person, you can refer independently for occupational driving assessments. But the caveat there is that they don't come cheap, unfortunately. I can't quote because the cost varies depending on the provider. Yeah. They don't come cheap. And so it's a really hard thing, particularly in the area that I work. It causes, I'll be honest, it causes a lot of stress trying to work with people with who you're concerned about their driving and concerned about their well-being and others, and having to provide that difficult information, particularly in rural and regional areas where people are so dependent upon their cars to see family and get around. But fortunately, we do have services in place that I try to get involved as soon as possible, like community transport and other half-price taxi vouchers, those things, to try to compensate and lessen the blow, I suppose, of receiving that information.
Still promote their independence somewhat.
Got to promote people's independence, and that's one of the unfortunate, really one of the hardest things about this for many people, particularly, as I said, in the areas that mostly work in regional Victoria.
Yeah. Okay, so our next question is, Mum was very confused when she went into a hospital to have an operation. She was seeing things that weren't there. After a few weeks, once home, this settled. She's pretty much back to normal. Does she have dementia?
So that's a pretty common scenario. And without much, more information about that sounds like what's occurred is a delirium. So a delirium is not dementia. A delirium is a temporary state of confusion that can be brought on by a range of different things. And one of the most classic examples is going into hospital and having an operation and anaesthetic. While people with dementia are more likely to get a delirium, it puts you at risk of getting a delirium. Having a delirium in and of itself isn't dementia, and there's a degree of what we say reversibility. It can improve a bit if you're doing the right things, okay? So with delirium itself, so there's a range of different things. So people might not be hallucinating and agitated. They might be very quiet and withdrawn. That can also be a delirium. Having a delirium prompts just keeping an eye on things, extra supports, and ensuring that there's adequate follow-up with the GP and referral onto specialists if there's need to, and particularly if there's not an improvement back to where someone was before all of that.
Okay.
Yeah.
Our next question is, and I guess we're asking you how long a piece of string is. Do some forms of dementia progress faster than others, or is it really based on the individual? How long does it take?
It's a good question, because it's really a combination of those two parts. So different dementias progress more quickly than others. Alzheimer's in general, if it's not the genetic type, and the genetic type is rare, I want to emphasise that, and uncommon. If it's not the genetic type, it's usually slower over years, and up to 10 years, depending on the person's other illnesses that make things collectively worse. Vascular dementia is slightly different in that if you think of Alzheimer's in terms of the memory and the function sort of going on a bit of a slope, vascular is a bit more step. So vascular relates to vessels, and when we say it relates to vessels, it can be related to small things like strokes or other events that you can identify a very clear time point when there was a step down. And people can stay on that level for some time. You control all those other risk factors that can put people at risk of further insults to the brain, but then there can be steps like that. Frontotemporal dementia is typically more faster moving in terms of the time frame. But in all of this, the individual, everyone's very different and experiences the illness differently, and the way they function is experienced differently depending on the environment around them and the supports they have as well. So everyone is their own person, and that's why tailored and individualised approaches are really important that are focusing on goals. In the later stages of dementia, one of the, I suppose, common ways I describe this is that it's not like superannuation funds where the recent past is not a good predictor of the future. The recent past actually is a pretty good predictor of the future. So if you've seen changes over months, you're likely to see more changes over months. And if you've seen significant changes over weeks, you might be more likely to see significant changes over weeks.
Okay. You spoke about genetics. Our next question is, how strongly do family genes affect the chances of having Alzheimer's dementia?
Okay, so this is a common question too, and I will point people to a really good resource who are interested in this. So it's dementia.org.au, which is the Dementia Australia website. If in this
fantastic website,
a fantastic website, and have you referred to this on your page yet?
Not on our page, but I do refer clients to it.
So do I. This is what I put enough all this information for people and point them to it. And if you go to the search section and type in resources, then in resources click help sheets. There's a good section about genetics in dementia. I'd really encourage anyone who's concerned about that to read it, and hopefully it allays and reduces some of your concerns. The genetic part of dementia for the genes, so the genes tell our body what to do and how to be, and there are genes that are related to dementia, but they're uncommon, and often if they do occur, it's generally in younger people. It can be as young as 30, but in the sort of 50s and 60s, and even up to 70s, and they tend to be more rapidly progressive types of dementia. So they're the ones we know have a link. There are a range of other genes that we have that we think might be related, but it's not really concrete. And so if your parent has dementia in their 70s, 80s, 90s, and they've had it for years, the genetic links are not strong. And we say that the most common form of dementia is what we say sporadic. So sporadic meaning coming on without a real known cause, and that's Alzheimer's dementia. But I'd really encourage people to look that resource up if that's a concern they have, because it does help clarify some of those issues there.
Yeah. I have had another question come through during our live. Jenny asks, when you say exercise, is a daily walk enough, or are you also talking about mental exercise, for example, crosswords, etc.? What can be done if physically the patient cannot exercise?
That's a great question, Jenny. I will start firstly with the exercise. So when we talk about exercise purely for the mind, there is a simple way to think about, is this exercise enough? And it's called the sing test. So you should be puffing enough when you exercise over a sustained period of about 20 minutes that you can't hold a note. So if you can sing and walk, then you're probably not walking fast enough to give you benefits for your brain. It doesn't mean that walking isn't good for your physical health and being social, but it's probably not going to benefit the way the brain functions. So doing that multiple times a week is really important. But obviously, as I described, dementia is related to aging, and other conditions are related to aging too, which may limit people's ability to physically exercise. Then engagement of the brain is really important. Now, the studies on this aren't as concrete, but just because the studies don't tell us things, it doesn't mean that things don't necessarily work. It's just we haven't got enough evidence. We don't know enough to be 100% sure. So I think of it as, will it do harm to engage someone's brain, to be more social, to wear hearing aids, to do Sudoku or crosswords? It won't do harm. Could it do good? Potentially. So any way that appeals to the person. So I think the most important thing if we're thinking about mental exercise is what actually appeals to that individual. getting people to do something that they're really disinterested in or they've never been interested in before is unlikely to allow them to their brain to engage to a point where they might get a benefit. So I'll always ask people about what sort of hobbies they had. Is there anything in woodworking or using their hands or even knitting or patchwork or crosswork, those sorts of things that can engage someone's brain that they might be really interested in and can help. And there's some emerging evidence about things like colouring books, adult colouring books as well, to engage different parts of the brain, what we call the visuospatial part, but also the emotional side of things as well. And there's also really a lot of use in what we call reminiscence therapy. So that's being able to reflect on times past and share stories. And family can facilitate that through storybooks and producing photo albums and those sorts of things, attach stories to them. And they might be stories that you said, oh, Mum, what's this photo about? And they tell you, and you write it down and you put that in a book and compile it for them. And that can be a really nice thing for memory, nice memories and mood, but also a bit of cognitive stimulation as well. But I will say that the evidence for this is not really strong, but it doesn't do harm, and it can certainly make people feel good.
Absolutely. I do have one more question for you. If anybody else in the community who's watching live still wants to ask burning questions, please do post it below. We will ask before Dr. Jessie Zanker goes. But I just wanted to touch back on why it's so important to see a geriatrician, especially for those families who do have a loved one with a diagnosis of dementia, why it would be in their benefit to see a geriatrician rather than their local GP in their local area.
So the way in which, I suppose there's a couple of ways to answer this question. So dementia can be diagnosed by a range of people. So geriatricians are specialists who can diagnose dementia. GPs in certain circumstances who have an interest can diagnose dementia too. But there are also neuropsychologists who are trained to diagnose dementia, psychiatrists and neurologists. They're the main sort of specialists who diagnose dementia. So it's not necessarily just a geriatrician, but each of those specialists has a generally different approach, and it's really about what you're comfortable with and your loved ones are comfortable with. So while everyone might follow the evidence base, the focus of what the care the clinician might provide might be slightly different. The gold standard for diagnosing dementia is actually in public cognitive and dementia and memory services clinics, but they are excellent, and they are a diagnostic service. So you might get a diagnosis, but you won't necessarily get the follow-up. Where a geriatrician can be really useful is in both diagnosis but planning with family and following up and living with people through this experience over the course of their experience with the illness, not just living in the community, but also transitioning, if they are required to residential aged care. And geriatricians in general pride themselves on focusing on patient and family goals. So while the disease itself is really important for planning and for treatment, it's really focusing on what does this person want to achieve? What are their goals and aspirations, and how can we help them achieve those in spite of this, which we'll manage as best we can. And I suppose we really work closely with GPs. We rely on GPs as part of the team to care for individuals, and other allied health as well. So geriatricians try to work with a range of people and stakeholders, and we will provide recommendations to the GP. The GP will provide us with information, and we keep open lines of communication in general about how to best care for that person.
Yeah. And I guess from my professional perspective, and also being a family member with someone who has advanced dementia and is in care, I have got nothing but profound respect for geriatricians. From a family perspective, my aunt has severe dementia, and that's her biggest issue. But when we had a geriatrician come in and review her, we also did advanced care planning. We did pain management and a few other bits and pieces, and it was just wonderful. So I think that aside from the whole dementia diagnosis, that it's really quite beneficial to have more than just that 15-minute, appointment with the GP. They actually go hand in hand very well.
Well, I'm really pleased that you had a good experience, but also sorry that it's about you said your aunt.
Yeah, my aunt.
But I suppose in a way that informs how you're conducting these very important forums for people as well, to share your knowledge and information. And I'm pleased also that the care that your aunt received was holistic, and that's a really important part of what we try to do is not just focus on the disease and the person's goals, but also other conditions that can make managing all those things more difficult, like pain, like issues with continence, like falls and mobility. All those things are part and parcel of the consultation with the geriatrician, and we all initial appointments, at least with myself and my colleagues, is at least 60 minutes to go through these things and try to come up with a plan and a follow-up plan.
We do have one more question, if that's okay, from Kathy. She asks, is the mini mental test a true diagnostic test for dementia?
Great question, Kathy. So the mini mental is the most commonly used test that we use to assess someone's cognition. So it forms part of the diagnostic workup, but it also forms part of how you follow someone up. So it tells us some things, but it's got its limitations and flaws, and the mini mental and performance on it alone, and looking at that alone, does not diagnose dementia. So for example, if I am seeing someone who scores 15 out of 30 on the mini mental, but English is their second language, I didn't have an interpreter, and or they never went to school or learned how to read or write, then that might be a normal score for them. So any test needs to be taken in the context of the individual, their experience, their education, their language, and also the norms for age at that time.
Sure.
But that's a great question.
Well, thank you for joining me tonight. Was there anything else that you wanted to cover that we haven't touched on tonight?
I think that's a pretty good range of questions there that covers most things. But I think keeping the discourse open is really important. Never feel like you're alone. There's always support there. There's never nothing that people can do to help support. So if you're finding it really difficult at times, then reach out for help. It might not come immediately, but it will get there. And using support groups like this to find out what works for other people is really important too. Yeah,
and sharing our experiences with one another, especially for those of us who have been through it before. I guess there's strength in numbers, especially if we can rely on each other. So, yeah, thank you so much for joining us tonight and taking the time to do this. Really appreciate it. And thank you to the community for, again, watching our live session. Coming up, we do have some extra sessions going to be talking about medical power of attorneys, financial power of attorneys, wills and estate planning. We do have another one coming up talking about how to approach the subject of care with your loved ones, especially if they're resistive. And I also have another financial planner lined up talking about means testing and what that actually means in terms of costs for aged care. So thank you again for joining us tonight, and we look forward to seeing you again next week. Good night.
Thanks, Naomi. Thanks, everybody.
Bye.